Okay, we can go ahead and get started.
Okay. Hello, everyone. Welcome to the Diabetes and Obesity Collaborative Lectureship Series. I'm going to introduce Ms. Qing Ye. Ms. Ye is the Graduate Research Assistant of the Department of Health Management and Informatics at the University of Missouri. And she is a Doctor Candidate of Informatics Institute. Today, her topic of the presentation is evaluation of provider documentation patterns as a tool to deliver ongoing patient-centered diabetes education and support. Okay.
Good afternoon, everyone. Thanks for coming for my presentation today. My presentation topics today is evaluation of provider documentation patterns as a tool to deliver ongoing patient-centered diabetes education and support. As we all know that diabetes is the most common chronic disease in the world, and diabetes self-management and support would benefit the patient with diabetes. It could help them to decrease their blood glucose and HbA1c. But based on data in 2011 and 2012, we found that only a small percentage of people with new diagnosed diabetes get their diabetes education in the first year. The number for the Medicare is 5%, and for the private insurance is less than 7%. So the diabetes patients, when they visit their diabetes providers, that's their possible opportunities for the patient to get their diabetes education. But the barrier is that there are very limited time when the patients talk with the diabetes providers. The statistic from 2018, it shows the U.S. primary care physicians spend time with each patient. We could see that less than around 11% of their physicians spend more than 25 minutes with their patient. So our research objective, we want to know the frequency distribution of the education, diabetes education information the provider provides to diabetes patients based on diabetes education guidelines during the follow-up visits. The second objective is we want to know whether the provider deliver the diabetes education based on patient characteristics, and there are differences of their based on different gender, HbA1c results, and BMI. The third objective is we want to access the involvement of the people with diabetes, whether they positive to share their blood glucose number to their providers during the follow-up visits. This slide shows the study design. We first created the code book based on diabetes education guidelines. Then we extracted diabetes on the clinical notes from the power chart. Then based on our code book, we coding on the clinical note sections. After that, we analyze the frequency distribution, and also we assess whether the providers provide individual suggestions for different patients. For the coding book, we use the AD7, American Association of Diabetes Educators Self-Care Behaviors, to create a code book for the project. The AD7 includes 7 principles: healthy eating, being active, monitoring, taking medication, problem solving, reducing risk, and healthy coping. For the monitoring, it's have the patient to check in and confirm whether the glucose number is within the target goal. For the problem solving, each physician provide the patient prepare in advance in some unexpected situation. For example, they have a hypoglycemia, or they get cold, or they need either outside in a restaurant. The healthy coping provide different ways to teach diabetes patients how to cope with stress, anxiety, and depression. This slide shows the example of the code book. It shows the monitoring principle, and based on AD7, we created each item of the monitoring to try to catch the most concept from the monitoring. So we use the ID of the code and the description of the meaning of each code. This slide shows the example of the patient clinical note. We use a history of present illness and assessment plan, these 2 sections, to catch the diabetes education material. This slide shows the clinical note section extraction process. First, we apply inclusion criteria in our power insight. For example, the age, the visit, clinical settings is a diabetes center, and they should be diagnosed as type 1 or type 2 diabetes. Had administered 2 clinical visits for diabetes. So we get our initial patient list, and we randomly select 200 patients. Based on a 200 patient list, we apply exclusion criteria such as to mark whether they use insulin pump or not, and the reason for their visit. So we choose the first 100 eligible patients for our study. Then we copy and paste the history and the present illness and the impression plan, these 2 sections in our Word, and also we remove the identification information. And based on the code book, we do manual coding. Also, we connect the patient data, including BMI, HbA1c, and whether they diagnosed with hypertension, hypoglycemia, and coronary artery disease. They also mark whether they use insulin pump or they taking insulin, and whether they share the glucose data with the providers during the time they visit providers. This slide shows the definition of the history of present illness. It's a description of the development of the patient's present illness. Impression and plan is a record of the clinical assessment performed to determine whether problem may affect the patient, and before plan the treatments or management strategy that are best to manage the patient condition. This slide shows the example of the coding process. It's an example of the history of present illness. We read the sentence of the clinical notes, and we use the code book to check whether the meaning of the sentence match the code. If it matched, then we put the code ID on the Word document. For example, the last sentence, she checked her feet and eyes, so we put the code related to monitoring feet and eyes on the document. After we do the manual coding, then we count the number of code based on each of the 87 principles across all our 200 clinical notes. Also, we do the description statistics. We calculate the mean standard deviation and the median of the current codes for each of the 87 principles. We also want to check whether the providers provide specific education to the diabetes patients. So we use the generalized linear mixed model to show whether there are different kinds of the codes based on the patient characteristics. For example, the age group we separate as people older than 65 and younger than 65 under the type of diabetes, under the history of diagnosed diabetes is more than 5 years or less than 5 years. And then also BMI is more than 30 or less than 30. And then the HbA1c result is more than 8% or less than 8%. This result shows the 100 patients' characteristics. We could see like gender and the HbA1c result may almost balanced, but some characteristics is balanced, such as the age. There are more young people than people older than 65 years old, and also most of the patients has type 2 diabetes, and most of them accept insulin treatment. Also, most of them have their BMI number is more than 30. This slide shows the count of codes across the 200 clinic nodes. So we connect the data based on the clinic node section, history of present illness and the impression and plan. Also, we categorize 7 principles differently. For the history of the present illness, we could see the monitoring has the most count of codes. It have 522 count of codes. But the healthy coping have the least count of codes. Only have the 54 count of codes across all the 300 clinical nodes. For the impression plan section, we could see the same situation. The monitoring has the most count of code. It's almost 1,300 count of codes in 200 clinical nodes. But the coping have the least count of the code. We also conducted the distribution inside of the principle under the section of the clinical nodes. Under it, for each clinical node, we could see the mean, medium, of the count of the code. And we could see in the impression and the plan section for the monitoring the mean of the count of code for each node almost 6. So it means the monitoring was mentioned 6 times for each clinical note in impression and plain section. So our research, key finding is that monitoring appears the most common self-management behavior in both history of present areas and impression transaction. The reason why it may be is because the insurance company requirements. Because the insurance company require the providers to document their blood glucose monitoring result and how often they record the blood glucose data to refill their equipment, and also in this study, most patients use their insulin, so the monitoring are needed to help their patient adjust their insulin dose. In the history of present illness section, the active is the least common self-management behavior, and the healthy coping is the least common self-management behavior in impression and plain section. The reason why they appear least common maybe is because the lack of time for the patient providers. So they document the most important things like taking medication and monitoring first. So they have few time after for document the active healthy coping. And the second reason is that the providers may discuss their being active and healthy coping with the patient, but they don't document it in the clinical notes. And the third reason is that the providers may provide comprehensive and individual diabetes education to the patient at their initial visit. They may consider it's not needed to discuss in the following up visit. For the result of the patient-centered education, and we found generally there is no different statistical, no difference of the count of codes based on the patient's factors. It means, for example, the providers, we provided a similar diabetes education on being active for people BMI more than 30 or the BMI less than 30. So the active count of code is similar. We only found that the providers deliver more information on the health eating to men and women in the impression and plain section. For the data about analyzed sharing the blood glucose data to the providers, we found 88% of the patients they share the blood glucose data during the follow-up visit to providers. So it means they have the active involvement of their self-management. For the future direction, we will conduct research to analyze why the providers have difficulty to deliver their diabetes education, and why it's hard to deliver the patient-centered education. And also the clinical notes it's not just a document material, it also provides a potential source for the patient to learn from their patient portal. It's a potential place for the patient for patient diabetes education. This is thanks for our research team, Dr. King, Dr. Khan, Dr. Warren, Dr. Simons, and Dr. Pecco. This is a publication and a presentation for our research team. Thank you.
Thank you very much, King. I really think the slides were excellent. The graphics in the slides were very good. Could you go back to the one the table? And I do apologize, yes, number 13, please. Yes. So if you look at that, what made you decide to use the A1C as 8%? Why not use 7.5 or 10? What was the reason for the 8% A1C?
These are based on the guidelines of the diabetes clinical guidelines. A1C is an acceptable, reasonable time for the diabetes patient. So we should all the patients.
I think one thing that might be interesting looking at all of this is if there was some way you could look for people, because you found that monitoring was the one that was most commonly used. And this is if you look at it, 53% had less than 8% and 47 had more than 8. But is there an imbalance even further noticeable in people that are above 8%? So if you look at it, I think you may end up saying that people who had an A1C of less than 8% may even less focus on monitoring and healthy eating and all of those stuff. And most of the focus for taking medication and monitoring was in people above 8%. And again, I think that's important as somebody that does diabetes. We have developed a tendency to focus on people that are uncontrolled. Whereas I think we should have equal importance to people that are not so uncontrolled, because then we can actually prevent so many complications. So that's something I do try to teach my students is, if they are coming in and their A1C is 7%, you should still advise them healthy eating, exercise, checking their blood sugar, because that is the group that long term you can save complications. So just might be interesting, might be some more additional information, especially if you are looking at people that are older, A1C is higher, on insulin. That's the group that we all focus on without realizing that other people are going to end in that situation if we don't do something every time we see them. Another interesting point is you made in one of your assessments where you said that maybe the providers gave all the information in the initial visit. Yes, and I agree. I agree the initial visit is very important. But a lot of times, after the third or fourth visit, patients are not even wanting to talk about diabetes. So to me, it's important at every visit to bring up these principles of healthy living with diabetes. So although they may have discussed it at the first appointment, it's unfair to assume that the patient remembers it at the 3-month appointment and at the 6-month